Dr. Bismar is Professor of Pathology, Oncology, Biochemistry, and Molecular Biology at the University of Calgary Cummings School of Medicine and Staff Pathologist at Alberta Precision Labs. I'm not going to read the rest, but I will tell you he is an expert in urology, pathology, and oncology, biomarkers, and novel signatures of prostate and urological cancer. He is well known nationally and internationally for his work and has several collaborative groups around the world. He has published more than 100 peer-reviewed articles on prostate and urological malignancies and is presented at various national and international meetings. So we are very lucky and very honored to have him donate some of his time to us tonight. So without anything further, I'm going to end my part of the show and turn it over to Dr. Bismar. Welcome.
Thank you, Brad, for inviting me, and thank you all for attending today. This is my second time actually here. If I remember correctly, I was here in 2015, so 4 years ago. I'm a pathologist, so I'm not sure if everybody knows what a pathologist do. So you actually don't see any of you guys when you're in the clinic. We read the biopsy material that the urologist or radiologist would do. And then we make the diagnosis of whether prostate cancer is there or not, and we grade it based on the current clinical guidelines, which I'm just going to briefly mention. So today I'm just going to be updating you on some of potential new therapies that are in the pipeline and some maybe signatures that we are working on with the hope that we will bring that to the clinic soon. So this is the Rocky View Hospital where I practice currently, and opposite to that, as you all know, is the Prostate Center at the 6th floor, where I have also some of small research space that I use for tissue procurement. And I also have my research lab at the Foothill Medical Center. So this is an old picture where probably, I guess like 15 years ago when I was young and don't have gray hair. So this is the, in here on the lower right is the Gleason scoring system that we use. So technically what I do is when the patient go to see the urologist or radiologist, they will poke the prostate with several ultrasound-guided needle biopsies, and then those get processed in our lab, embedded, and then we would cut sections of that. The sections would look like this. We stain it with something called hematoxin and eosin, and then I will look under the microscope and make my final decision whether I see cancer or not. And if I see cancer, I will estimate the amount and grade it based on this Gleason score, which is mainly a system to differentiate the tumor based on the architecture of the cells. So, as you all know, prostate cancer is one of the most common cancers affecting men in the Western world. The prostate-specific antigen, which is the serum marker, remains the major screening tool and the most widely used serum biomarker for prostate cancer diagnosis currently. The caveat for PSA is that it's not ideal because it overlaps with benign prostatic hyperplasia. So someone with elevated PSA levels can or have benign prostatic hyperplasia or can have cancer or can have neither. Although there is certain cut points that they use, it's not perfect. So if we say diagnosis for prostate cancer for patients or men with low serum PSA below 2.5. At least the estimation is that 15% of those will actually still have prostate cancer. So currently there is no like a midpoint or a point to say, okay, this is cancer, this is not. So it's a gradient. So what we do, or the current treatment options, as you may know, is surgery, radiotherapy, also more and more awareness or implementation within active surveillance programs are being implemented. There's also hormone and chemotherapy for advanced disease. And then potentially on the market, there is some specific targeted therapy that they could use for more rapid disease as well. So serum PSA, this should be carried out along with digital rectal exam and consultation with urology to assess for various risk factors. So obviously the patient age, the family history, they take all that into account. The absolute value of the serum PSA is important, but also sometimes the urologist would look at what we call PSA doubling time. So technically they look at 1 point of PSA at this time, and then they see how long it will take to that value to double in time. So the shorter the period, the more likelihood the disease is progressing. And then also there's potentially what they call PSA density. There's also a few other newer PSA-linked tests, like for kallikrein PSA serum testing, that has been used also in the United States mostly. So for criteria for advocating patients to go on into active surveillance, usually this is reserved for patients with low or low intermediate risk that we think they can be optimally managed in such programs. Usually these patients would have Gleason score 6 or 3+4 with currently used to be about 3 cores, but I think now mostly they're expanded up to 5 cores out of 12 positive. And if PSA, the optimal is that PSA is less than 10, but they have been enrolling patients with higher serum PSA. The Gleason 4 should be limited and no more than probably 10 to 15%. And also, according to new criteria, should not be, I guess I'm going to use some clinical terminology, cribriform pattern, which we usually see under the microscope. So if someone is having cribriform pattern 4, usually we advocate not to go on active surveillance because of the data now showing that this type of, or this pattern of prostate cancer is associated with a higher rate of progression. So currently the estimation is that about 10 to 30% of such patients may exit active surveillance program on a yearly basis, and that could be due to either anxiety on the patient side, because when someone is on active surveillance, they would require yearly biopsy, yearly serum PSA. There's a potential for obviously infection, bleeding, hospitalization. So they may put the patient under certain anxiety, and they sometimes prefer to exit such programs rather than going through the repeated biopsy. There's some suggestion that a couple of markers that we could test on tissue can have association with disease progression, and therefore we are investigating whether we could use them to tailor the decision of not necessarily telling the patients to go on active surveillance or not, but actually to guide the frequency of prostate biopsies for patients. So for example, if someone having a P10 loss, we would potentially advocate that patient go under more frequent biopsies compared to patients who doesn't have PTEN loss, where he could maybe spare yearly biopsy and go every other year or something like that. So we're still working on this potential tissue-based test, and we currently have grant support from Prostate Cancer Canada to look into this, plus additional molecular signatures to help us guide the treatment. So there's currently what we call second-line drugs for advanced prostate cancer, new hormonal therapy drugs being developed, enzalutamide, Abi, that they can use with or without docetaxel. And there's also currently a plethora of or several drugs targeting the damage repair pathway, DNA damage repair pathway, and they are called PARP inhibitor. And those are targeted for tumors that have either somatic mutations and potentially germline mutation as well in this pathway. So my role is to, beside the clinical diagnosis, is to try and develop molecular signatures that could differentiate aggressive and indolent prostate cancer, and then can be implemented clinically to aid in better decision making for patients. So we have currently several commercial tests that has been developed by companies. So there's Decipher, there's a Prostate Cancer Oncotype DX, there's a Myriad signature related to cell cycle. There's also a urine test which assesses the TMPRSS2 ERG gene fusion and PSA3. And as I mentioned, we are looking into employing some tissue-based markers like ERG and PTEN, and we have also a 10 gene signature that we are hoping to look into for active surveillance population. So what I do in the lab is I usually start from looking at the archival tissue that we have in the pathology for prostate samples. I look under the microscope, characterize them, circle these areas, and then what we do is we profile these samples. So we will look at the genes expression and also on the copy number of these genes, so whether the genes are amplified or deleted, and also how much they are expressed, overexpressed or underexpressed. Then we will validate those in other cohorts that are available publicly, and then we build tissue microarrays, which usually we will take samples from each of these samples, and then we will put them all in one slide. So each slide, instead of having one patient sample, we could put up to 300 samples on one slide, and then we would be able to add or assess the protein expression or the DNA copy numbers individually on these 300 samples, and then we will look at outcome and try to associate specific mutations or specific gene expression with better or worse outcome to bring potentially new signatures for prostate cancer. So currently what we have is we're looking at 10 gene signatures, or 10 gene signature that we investigated initially in prostate cancer patients. We validated this at 4 cohorts, and we showed that this signature is able to predict metastasis biochemical recurrence at later stages. So now what we hope is that we want to validate the signature into active surveillance to see if we're able to actually stratify the patients more accurately. So as you can see here, the 3 Kaplan-Meier curves are different cohorts. This is this cohort from Sweden, this is from the US, This is also from the US, and we show clearly that there is a difference if you use our signature versus using just ERG by itself in predicting prognosis or disease progression. Obviously, this is still need to be validated, so it's not yet available clinically, but we are hoping that this could be soon available to help potentially guide some therapy decision. And this only showing the value of the signature in patient within this group of Gleason score 7, that you're able to actually differentiate more accurately than just using Gleason score by itself or Gleason score plus ERG for predicting lethal disease with a higher hazard ratio, 2.52 as compared to 1.8. So the couple of new, I guess, potential markers for prostate cancer is something we rarely see this type. So there's a morphological variant of prostate cancer called intraductal prostate carcinoma. And this usually associated with higher rate of invasive cancer and also higher grade of prostate cancer. So Gleason score 8 in about 50% of those patients who have intraductal carcinoma usually present with high stage, usually with metastasis, and also the presence of intraductal carcinoma has been associated in several publications as an independent predictor for biochemical recurrence and survival in prostate cancer patients. So what's coming now is that if we detect intraductal carcinoma within the biopsy, then those patients should not be on active surveillance because of the potential higher rate of disease progression. But what's more important is actually if you find this intraductal carcinoma of the prostate without additional invasive carcinoma, the potential for it is that these type of tumors can harbor specific mutations at higher rate compared to invasive cancer, and these mutations are within the DNA repair genes. So if any of you heard of like BRCA1 or BRCA2 mutations, there's also CHEK2 mutations, CDK12, FOXA1, and SPOP. And so the advantage is that although this disease is associated with more progression or higher rate of progression, because there is a higher rate of finding these mutations, then they'll be amenable to these new targets like the PARP inhibitor drugs to slow the progression, and they respond better than just tumors with no mutations. So you can see in a publication my colleague had, they looked at 15 cases and they found that the rate of this actionable mutation is higher compared to regular type prostate cancers. Similarly, there is another type, morphologically is close to this one, but it's called ductal type prostate cancer. It's a rare variant and estimated to be about 3% only of all prostate cancer diagnosed. This type of prostate cancer is characterized by large glands with pseudo-stratified columnar neoplastic epithelium. So it looks like an endometrial or endometrioid cancer. So it looks like that. So usually you have more papillary things, it's condensed and high grade. So again, this is associated with higher rate of progression, but there is higher rate of detecting these mutations in this type as compared to regular cancer. So We did a study where we looked at 51 patient samples with this specific morphological variants, and we showed that although 57% or more than half had higher stage 3, and 25% actually lost their life because of this disease, and 43% had metastasis. More than half of those tumors actually have one mutation within this DDR pathway, which suggests that those patients would be able to benefit from the newer drugs on the market. And currently there's probably 4 or 5 drugs being tested in various centers in Canada, and there's a couple of trials actually at the Tom Baker and the Prostate Center that we are actually enrolling patients to test for these mutations with these newer drugs. So those drugs usually are for castrate-resistant advanced patients, but we're also looking at it, at least for research, for non-metastatic castrate-resistant patients as well, to see how often we can detect those mutations and correlate that with the morphology. So again, this is just showing you the wealth of the number of mutations that can be detected. All of these mutations can respond to this PARP inhibitor, and those can be detected either in the tumor, but it also can be associated as a germline mutations. And the value for that is that if someone has this mutations, they would be able to kind of advocate for the relative of the patient to be tested as well, because of the higher risk of potentially developing prostate cancer. Some of those genes you may or may not know, like the BRCA1, BRCA2, are also associated with like breast cancer in female and ovarian cancer in female, so they can be associated with other cancers as well. So again, this DNA damage repair mutations, about half of the patients would had at least one mutation in this pathway, and overall 14% had evidence of mismatch, microsatellite unstable alterations. So those are the same mutations that happen also in colon cancer. So now, similarly, potentially the drug that can be used for colon cancer, they can be used here if patients have these mutations. The other type of mutations that just been characterized recently is something called CDK12 mutations, and those are present in about 3 to 7% of metastatic prostate cancer, and also define like a specific signature of the tumor by being genomically unstable. So again, those are associated also with higher rate of disease progression and metastasis, but the value is that you actually can target them with novel targeted therapy, including PARP inhibitors. And also the patients who had this CDK12 tumors potentially have increased T-cell infiltrate within their tumors, which suggests that maybe they may be able to also respond to some potential immunotherapy. And so currently they're looking at this as well, so PD-L1 therapy as well. So just briefly, the other type of prostate cancer or aggressive prostate cancer that we look at is also something called neuroendocrine prostate cancer. Usually is characterized by dense small blue cell tumors like this. And this type of tumor can happen de novo, which means they can happen originally by themselves. The rate of this type of tumors is about 1%, but the rate can be increased to 20 or 30% in patients who have been subjected to either hormonal therapy or radiotherapy. So for some reason, we don't understand yet the molecular association with this. Up to 1/3 of patients, if they treated with hormonal therapy or radiotherapy, they can develop this type of dedifferentiation. And unfortunately, this type is associated with really rapid progression of the disease and metastasis, and unfortunately, lethal outcome. And so what potentially is happening is that with the addition of all of these newer drugs of the hormone of the second-line therapy, we may be putting selection pressure under tumor and therefore selecting these clones to actually proceed and progress. And so currently this neuroendocrine prostate cancer as well, the issue with it is that where we try to characterize it under the microscope as pathologists, we usually are faced with morphologically similar tumors. They look the same, but then when you test them for neuroendocrine markers or for AR-associated markers, they do not, all of them show the same type of markers. So some of them are neuroendocrine positive but AR negative, some of them are neuroendocrine positive but AR positive, and some of them are double negative. And so we are still trying to understand what's the difference, if any, between these three subtypes that can be associated with potential targeted therapy. And so as part of looking at this, we, for research purposes, we characterized a 212 gene signature that we can apply to localized disease and identify potential neuroendocrine prostate cancer signature or behavior of tumors that can develop into neuroendocrine upfront before the treatment. And we also showed that these this signature is clearly able to differentiate this neuroendocrine from other tumors like the irregular acinar cancer or the poorly differentiated ones. And we also showed that potentially these neuroendocrine tumors, they could potentially able to respond to this PARP inhibitor. So you can see there's olaparib, rocanapib, and other drugs that can also work as PARP inhibitor, histone deacetylase inhibitor, and histone methylation inhibitor. So these drugs, some of these drugs are being used actually in lung cancer currently. And what we showed is that this type of tumor is closely mimicking lung cancer, at least molecularly, and so therefore they would be able to respond to the same type of drugs that are offered for lung cancers in prostate cancer, and they show very good response. So in conclusion, we have kind of like three main points is for patients within the active surveillance or patients who are considering active surveillance, the critical point is the number of cores, the extent of the tumor, and the Gleason score. So at least for now are limited for 6 and 3 and 4 minimal with no cribriform or intraductal prostate cancer. ERG and P10 may aid us as pathologists in identifying intraductal carcinoma versus high-grade PIN, but we still rely on the morphology with a high suspicious index. Ductal prostate cancer as well as intraductal prostate cancer are important to be recognized as they signify worse clinical outcome and higher rates for actionable mutations and potential targeted therapy. So in short, what I do is I try to employ molecular markers to differentiate two similar tumors that they look similar under the microscope, but they actually have different behavior. One could be calm and one could be more hyper person. And in that, I acknowledge my sponsors, And I'm happy to take any questions. Thank you.
I just have a general question. How long do you say do you keep post-op prostate tissue? Do you keep it? And if yes, can you now do some of your studies, say,
In here we have tissue from like mid-1990. So they keep them up to like 30 years or so. Yes, so we usually, that's what we do is like we go back and retrieve those samples and investigate all of these signatures, because the advantage also that we link our research with Alberta Cancer Registry, and so we'll be able to kind of know what happened to all of these patients. So then if we find potential genes or something, we'll be able to know if this is associated with a better or worse outcome.
A few slides back, you used the word immunotherapy.
Yes.
What exactly is that, and when is it used on any type of cancer, not just particularly prostate cancer? What does it do?
So the immune therapy, my understanding is that it acts on the immune system, but it will only be beneficial for tumors that they express higher levels of what they call PD-L1 expression, which is a marker associated with immune infiltration, so inflammatory cells within the tumor. So not all the tumors would express this marker, and not all the inflammatory cells would express this tumor. So if patients' tumor express those, they would be able to use this type of therapy. So it's not chemotherapy, it's like an immune therapy. So it works on the immune system, trying to simulate it to make it work probably in a better way to kill the tumor. And they actually showed some better responses. It's mainly used now or approved for lung cancer. There's currently some clinical trials for renal cell carcinoma, bladder cancer, and for colon cancer. For prostate, there is some limited response. The issue for prostate is that usually it's not associated with brisk inflammatory response in the tumor as compared to others. So that's why the immunotherapy may not work in prostate cancer in general. But what we are trying to look at, like those specific types, they could be associated with a higher immune infiltration and therefore be amenable to these drugs. So one of the issues is that because this type of cancer is rare, like ductal cancer is only like 3%. So if you have like 100 patients, you're only gonna find 3 patients that they're gonna respond potentially to this drug. But what we found is that because of those mutations, so if you look at the 100 patient, the rate of these mutations is only like 5%, 6%. But if you look at within these 3% of patients that they have the ductal, the rate of those mutations is about like 50%. So almost always, if you have this type of cancer, you will have those mutations. So what we're trying to do is to advocate or increase the awareness among pathologists even to recognize this type of tumors. And currently we just submitted a grant to CCSRI to look at this type, the ductal, the intraductal, and there is some what we call cribriform because the features are slightly overlapping. So we hope that we're able to expand the investigation, and if all of these morphological variants include higher rates of these mutations, we could be talking about 20 to 30% of cancers, depending on where you find it. Yes?
I'm interested in your opinion as a pathologist. So when somebody undergoes a prostatectomy and there's pathology done on the tissue, and they come back with whatever might be called a negative surgical margin. You know, they assume that they've captured it all, or it's contained within the prostate. But then about a year, maybe a couple of years later, the cancer comes back again. In terms of the pathology of it, why is it that it's supposed to be contained, and they sort of did the pathology report afterwards and said, yes, it's still in the prostate, but in fact, it may come back later. Your thoughts, and I recognize that cancer cells can migrate anywhere. What's your thinking?
So, what I'm thinking is that you usually so we see it under the microscope that it's confined and there is nothing outside the prostate that we can see, but obviously there are probably what we call circulating tumor cells. Okay. So those can kind of escape initially and go in the circulation, and for the most part, even if they are in the circulation, they usually do not really cause recurrence of the disease. But what's happening is that you have these circulated tumor cells, and then they go and lodge, usually in bone marrows or these things, and then for some reason and some cofactors, they reactivate and they kind of gain. I think what now the notion is that they become more epithelial to mesenchymal rather than mesenchymal, and then they start the process of prostate cancer being now originating in metastasis, and that's why. So usually, for example, if you look at prostate cancer patients, so only 15% would actually develop biochemical recurrence after let's say 5 to 8 years. And out of those 15%, only 15% actually gonna develop metastasis. And out of those that develop metastasis, only 15% actually gonna die from the disease. So for the most part, patients outlive the disease and metastases don't really form. But for some reason, because you have genetics, then you have the host environment for the patient himself. In some patients, they could have reemergence and then they develop metastasis. So unfortunately, when we look under the microscope, even though that we see that everything is confined and nothing at the margin, or there's no T3 stage, so there's no tumor in the fat or anything, we can't predict what's gonna happen. And that's why there are these tests in the market, but the problem with these, they will give you only a probability. So they would tell you, okay, you have 90% chance of developing metastasis within 5 years or 10 years. And so there's two things. First, they are significantly, well, not significantly, but they are costly compared to other things. So potentially, they may not be covered for public health system. But on the other side is, even if they say, okay, you have 90% chance of developing metastasis within 5 years or 10 years, currently there's no studies to kind of say, okay, so if we have this information, what are we going to do different now? So should we give radiation? So should we start with hormone? We don't know yet, how to do it. So even if we have this information, if we don't know what to do with it, it's kind of useless to actually.
Do you track what percentage of those cases where you think it's fully contained and has been caught, that it reoccurs? Do you have any idea of what percentage of what error there might be in terms of that situation?
If we are talking about T2 disease, so disease that is not in the extraprostatic fat and it's confined, then the covariate is what Gleason score it is. If it is Gleason score 6, 98% will not come back. If it is 3 plus 4 and there's no cribriform in the 4, I would say maybe 70% would not come back. then, if you had the cribriform or if you had a higher Gleason score, then there is more likely. Because the issue is when you have the tumor at higher grade, then there is more likelihood that some of the cells escaped into the circulation prior to actually removing the prostate, and that's why you end up having metastasis.
So the Gleason score is the covariant.
For now, yes. I mean, we can't say that all 3+4 they're gonna recur or they won't recur, and that's why we're trying to do these markers. Because also, like currently now, we say, okay, if you have 6 or 3+4, you could go on active surveillance, but some of them may progress faster than the others. So what we're trying to do is do these tissue-based tests, IHC, and see if they have, if they have certain mutation or decrease of this protein expression, then we could say, okay, maybe you should actually not waste your time and go on active surveillance, but rather have the surgery right away. Or we could say, your disease is really not gonna progress, so you could be assured to be on active surveillance for some time. And even if you're on active surveillance, you may not need a yearly biopsy. You can wait like 3 years to get the biopsy, etc. So that's what we're trying to do.
I'd just like to have you work us through the linear pathway of awareness relative to prostate cancer and the testing. I have the feeling that the family doctor is not particularly engaged with early detection of the disease. But if he has a suspicion, then it goes to the urologist. So what percentage of our population actually is getting to the urologist? And what are we missing in terms of early detection with this population that is not actually being seen by the urologist, but are being seen by the family practitioner?
All right, so I'm not a politician, so I may not know 100% about it. But
I'm coming towards your genetic testing.
I understand. So one of the issues is the serum PSA, as you know, I'm not sure where it stands as of now, whether it's covered by the health authority or not. So I know that it's at certain age.
Come at it technically, don't come at it from the point of view of whether it's covered or not.
No, but what I'm saying is like because of that, right? So if it is not covered, then there will be a hesitation, for example, on the part of the family physician to order it. So if he doesn't order it,
Order a PSA test?
what, sorry?
To order a PSA
Yes.
test?
Yeah, so if he doesn't order it, then he's not going to be, suspecting it. And then you end up, even though that we say it's a disease of older age men, you can still have those younger men that potentially, they have family history or they have these, what I refer to as the germline mutation. And those are associated with a higher risk of disease at younger age and even with higher metastasis and recurrence. So if the family doc is not, he's not requesting these tests because they're not covered or so forth, he's not going to be following up, and maybe he's not taking a detailed history to see if this specific patient is higher risk patient because of family history or, the germline mutations, then testing should be done. So that's I think the major issue. And because of all the issues, okay, does PSA test saves life? It's not costly because you have to screen, 400 men to kind of...
That's largely all a pile of crap.
Yeah.
As far as I'm concerned.
Yes.
The focus is all wrong.
Yes.
And my oncologist did bring in a family doctor into one of my sessions, consults. And once I realized where this chapter, what the purpose of the meeting was coming from, I got on my soapbox. Mm-hmm. And I was allowed by the oncologist to do that. This family physician only was submitting, or was only doing 3 tests. Only doing digital rectal examination? and not doing PSA tests on a serial basis. And there's a lot of evidence in the literature that serial testing of PSA can stratify, as you use the term, men that are at higher risk than other men.
Yes.
That's not an expensive test. I don't understand why the medical profession doesn't come to use what is possible, and particularly statistically, and then tie that in with your blood test sampling to help further identify men who are at risk.
Yeah, so,
It's at risk. It's not whether they have cancer or not, it's at risk.
yes, so it's,
Well, what good with knowing your risk?
Well, then
What did you do?
the referral goes to the urologist who actually do a biopsy. You always need the confirmation of the biopsy. I don't think a surgeon will go anywhere close to you unless there's a biopsy.
I see.
So it's all the question of how do you use that test in advance of actually being confident to send a recommendation for a referral to a urologist.
exactly. And I think one of the issues potentially that they view that the PSA testing is not specific for prostate cancer because it can be elevated in PPH or whatever, but that's what you have. I mean, that's a test that you have. There are other tests that are more accurate. For example, the ERG test in urine is more accurate because it's only detected in prostate cancer. It's not occurring in normal, but it only can capture up to like maybe 50% because only 50% of prostate cancer have this fusion. So if you don't have the fusion, if you're of the 50% that they don't have the fusion, obviously you're not going to capture it with this test.
See, the problem that I see is that there's always got to be a referral, and then the system kicks in.
Yeah.
And that's not capturing.
exactly. So if the family doc doesn't really
And your
understand that,
I
yes.
think your test has potential to help stratify people before they go to the urologist. I think.
No, my test is going to be able to tell whether the patient have indolent or higher risk disease.
Correct.
It's not diagnostic as of now.
Yeah.
Now, I was just at the Prostate Cancer Foundation in the USA retreat last October, and actually I met a scientist from Texas who she said that she has a paper that she looks at biochemical composition in the urine to actually say that you have cancer or not cancer, because she a biochemical assay differentiate between, for example, me as Middle Eastern patient versus someone else from Asia or from North America. The composition is different. It will also differentiate men from women because of the sex hormones, etc. And she said that her initial observation was that her compound, the rate of the area under the curve, which we measure, for example, PSA is only like PSA is 0.57. Her test is like 0.85 or 0.82, so it's clearly higher, much higher. And so I asked her if she would collaborate, because we have all these samples now from patients in Calgary, and we can just run the test and see if it is more accurate, because it's much cheaper than the various tests on the market. And you can do it anywhere because the machine is not proprietary for herself. Like, you can get the machine anywhere and just have it in the labs and test these things for you. So potentially they could be more accurate tests than PSA, but we just need to kind of understand the suitable way of ordering these, streamlining, potentially educating the family docs what to look for, because I think mostly is like if you take a very detailed, good family history, and if you do maybe a baseline PSA, let's say at 45 or 50, pretty much are set. You don't need to repeat it every year. Once you have it with the family history, you would know like how often you would need it and when you would need it. But if they're not doing this, then potentially you.
Well, our digital examiner, I put 2 papers in the last, I don't know, October or November, a digital examiner about the value of baseline testing. And it's phenomenal. I'd like to see that tied in with some of the bioassays and biomarkers that you're doing, or Dr. Lewis up at Edmonton is doing. So another point. That's one of my soapboxes. I was surprised that in active surveillance, you're prepared, or at least somebody's prepared to set a less than 10 as a PSA number for people not to qualify into active surveillance. My own view is that that's far too high. But
so the notion is that if it is above 10, they don't recommend to go on active surveillance.
That's right.
If it is below 10, then they would recommend it.
I find it hard. I find it really hard to think that Dr. Klotz would be advocating something more than 10, or something as high as 10.
Well, yeah, so it depends. So each program is different because currently there's no clear-cut standards to say, okay, these are the criteria for patients to go on active surveillance. So what they're trying to do, I mean, obviously they prefer patients with lower PSA because the chances of progression is low. On the other side, they would want to maybe capture more men to be eligible for active surveillance, to try to have them avoid the unnecessary surgeries if possible and side effects of the surgery. So they want to increase the base of adding patients. Because also one thing that we don't know 100% is what is the critical value for PSA. Because someone PSA of, let's say like, if you have someone with PSA of 8, he may not have prostate cancer or any risk for prostate cancer, but someone else with PSA of 3, he would have a high risk of prostate cancer because the ethnic background, the metabolite of the patient, the man. So we don't know 100%. Like I see a lot of even prostate biopsies where it comes and like the PSA is like 11 or 12 and this is like his 5th or 6th prostate biopsy and it's completely negative. So clearly we don't understand what's the kinetic of the PSA itself to say, okay, this has high risk. Because usually like if, my understanding if you say to someone, what's his PSA? And if he tells you it's like 8, you'd say, oh yeah, he's pretty sure he's having cancer, but that's not the case. And so what they're trying to do is just expand the criteria to add more patients into active surveillance because the notion that, okay, if you did surgery or you did radiotherapy, there's a side effect, there's incontinence and all of these side effects that they try to have men avoided. But on the other hand, within this active surveillance program, because now there's no set criteria, everybody gets almost like yearly biopsy or serum PSA or whatever. So the notion is that can we actually stratify men within the active surveillance? So rather than having just one group, maybe you'd have 4 groups. So like high risk, intermediate, low risk, very low.
I just think you're possibly misleading the individual that has genuine intermediate risk prostate cancer to put that person onto an active surveillance program.
What I mean, like, I don't understand the question.
But they're not doing that just based on PSA, though. You're basing.
You have to have the Gleason score, the extent of the tumor. So it's not just by PSA. So
Anyway, merging those, I was surprised when he was merging those 2 groups happening.
the merger between,
Low risk and intermediate risk. And
well,
putting both into active surveillance.
because they're trying to capture more men, because now the notion is that initially, for example, they would only put low-risk patients, so Gleason score 6, no 7, and like 3 cores positive, no more than 50%, whatever. Then they thought, okay, we're doing this, so almost like we're not seeing anybody that much progressing. So they wanted to increase the base of allowing people to go into active surveillance. But on the other hand, when you allow more freedom in the criteria to include in the active surveillance, you're going to end up with more men progressing or exiting. And that's why what I'm advocating is that if you want to include wider base, you will need to employ these molecular tests to be able to accurately tell the patient, yes, you should go, or you're okay to go on active surveillance, or no, you shouldn't. Because if you know, so me as a pathologist, when I look at the prostate biopsy, I'm only seeing very thin sample of tissue. So when I say it's a 3-3, there is still about 20% chance that it's going to be 4 on the radical. I can't tell because of the minute amount of the tissue. And so even if I say like it's a 3, maybe it's a 4, I can't tell 100%. So the idea is that if you employ these markers, then you have an added layer of saying, okay, if I'm saying 3-3 and add these markers, if the markers is pointing that the disease is aggressive, then those patients should not be on active surveillance, regardless of other parameters.
One final question. I'm with you there in favor of the biomarker coming in to help. When would we begin to see that in the clinic in a positive way here in Calgary?
Here in Calgary.
5 years?
So I would estimate probably 3 to 5 years. One thing is that it's not just that if I be able to show in multiple studies that it's important or it's of benefit, because then we have to come up to the hurdle of, okay, we have now to talk to the health authority and figure out, are they going to cover this test? Talk to the lab, we have to do it, and we have to do clinical trials, basically for saying, okay, now we're gonna, let's say like I determined that we had several publications, not myself, but like from several groups, that P10 by itself, if you have loss of P10 by simple immunohistochemistry, you have higher chance, almost like 2 or 3 times the chance of progressing. Now, we're still like in talks to try to see, can we implement that in active surveillance to stratify patients? And then would the health authority actually cover that test? I mean, my inclination is that they should cover it because it's a very simple test. It's easy to do. It's done on the tissue. It's much less of a cost comparing to doing yearly biopsies or even yearly serum PSA. It costs like $100 or something, or even, well, actually less, probably like $50. One of the issues is that sometimes you can have heterogeneity within the tumor itself. So one marker can be high, one test can be high, one test can be low, but you have to take the average. So still working on these logistics. But I truly estimate that within 3 to 5 years, we will have a definite signatures that we'll be able to employ in active surveillance. And actually, the grant that I have, we're supposed to have meaningful results by the 3rd year, which now 2 years from now.
Oh, for your research program.
Yes, we're supposed to have by 2 years from now, we should have a definite answer, and then this would be the step to actually do clinical trials. Then you get enrolling patients, do the testing up front, and follow them up and see how they're going to do. Yes, thank you.
Can you get these tests done now in the United States or something and pay for them?
Which test? So,
The-
let me just go back.
The P10 ERG?
Yeah, you can even do them here.
You can do them here and pay for it? Yeah?
Yeah, you can do them in the, see the thing is, So there's a couple of things you just have to keep in mind. We can do the testing in the research lab, but the guidelines for accepting the test by the health authorities is that these tests has to be done in a specific clinical clinical testing setting. So for example, I do my research. For example, I stain all my cases with ERG and P10, and I publish on these. I do them in the research lab that is part of Calgary Lab Services. They won't allow me to report these findings to individual patients because I did them in the research setting. They have to be done in the clinical part of the lab. So for me to move it from the research setting to the clinical lab, then I have to talk to for example, the Calgary Lab Services Board to kind of tell them, okay, now we did this, there's value of doing this. You have to bring the urologist, the oncologist to advocate for it, then convince the Calgary Lab Services Board, for example. Then these people would go and talk to the health authority, AHS, and say, now we want to have this done in the lab. So for example, I don't know, like if you probably know that, for example, for breast cancer, they all do like ER, PR, HER2. For colon, they do this MSI testing. For lung, they do the EGFR, the ALK, what else? The EGFR. For prostate or GU in general, we don't have anything actually to do. So that's why we're trying to advocate. Can we actually start with something? Like those are simple IHC similar to breast or lung or colon that you're actually doing for other cancers. Why can't we employ it to kind of help us guide active surveillance management like currently, right? Just do it on the tissue, and then the patients are already in the active surveillance. Just do it, and let's see the results in like 2 or 3 years. What's going to happen?
So just further point on that, I think it's called NCCN.
Yes, the clinical criteria. Yes.
Puts out in the U.S. Protocol guide, and they are now advocating germline testing for certain disease conditions in prostate cancer.
Yes, the germline mutations. Those are the ER that I mentioned.
Yeah. But just further to your point, then the barrier to you advancing this technology further into the clinic is to actually develop the clinical capability for the analysis versus the research capability. I'm hearing that as a barrier.
We can analyze it, there's no problem. But they won't allow you to test, like for example, let's say if someone comes to me and say, can you test this sample for me? I will do it in the research lab. And it's accurate, 100%. It's valid. But they won't allow me to report it, they won't allow me to put it in the report to say that this is positive or this is negative, because it's not in CLIA-based labs. So we have to bring it to CLIA-based labs to allow it to do. And it's technically going to be the same methods that they're going to use, but it just have to happen in that room rather than in my room.
All right.
Right. Thank you.
We'll cut it off there.